retinal dystrophy characterized by severe visual loss. This first starts with night blindness, that it progresses to complete blindness over the period of time. So, coming to the
you can be a little closer to the microphone, please.
The other mic.
This one. Coming to the pathogenesis, it has been postulated that decrease in the growth factor levels in the photoreceptor microenvironment is implicated as a cause of apoptosis and cell death. Not all photoreceptors die at once. Some die, while some others, because of the harsh environment, go into the G0 phase. It is hypothesized that introduction of growth factors can significantly slow retinal, not only significantly slow the retinal degeneration cell death, but also reverts back cells from G0 phase back into active cell replication. So, as the apoptosis is going on, there is a loss of signal output from the sensory rods and cones to the neural retina, and bipolar cells, and that leads to a phenomena called de-afferation of neural retina, and that leads to some phenomena called remodeling at the cellular level, which is characterized into phase 1, 2, and 3, and reprogramming at the molecular level, that is the rod bipolar cells, which is converted from on rod bipolar cells to off rod bipolar cells. The graph which we see in the multifocal ERG is the activity which is shown by the bipolar cells. So when the bipolar cells become diseased, the graph which we see becomes distorted. So why we reached for PRP? PRP, as we know, is a rich factor for certain growth factors like PDGF alpha-alpha, beta-beta, alpha-beta, transforming growth factor beta-1, beta-2, VEGF, BDNF, and epithelial growth factor. As well as it has got molecules like fibrin and fibronectin, which serve as the connective tissue constituents to help epithelial migration and adhesion. Hence, PRP was chosen for this study. As we know, autologous PRP was chosen, and it's the best part of this is it's free from the transmission-related risk factors. The reason it has been why we chose PRP, because it was already been used for many things like for musculoskeletal disease like hair regrowth therapy, in wound healing, in graft survival, in oral maxillary surgery. So we chose two routes. First was the suprachoroidal route, which I used my own indigenously designed needle to inject the PRP, and the rest subtenons used, which was act as a depot preparation. This is the needle which I have used, for which I already got a patent. There were four parameters which were assessed. First was the visual acuity by ATDR chart was noted before each injection and were followed till 6 weeks from first injection. Then multifocal ERG was done pre and post 6 weeks. Then OCT was done and perimetry was done. Though no significant changes was seen in OCT and perimetry, but for the first time in this particular disease, RP, improvement in the visual acuity and was noted, which was corroborated by the multifocal ERG response. Namely, there was change in waveform from abnormal to trending towards normal in trace array graph of multifocal ERG. Strength of response, increase in heat map in multifocal ERG. Significant increase in the amplitude density in all the three rings, namely for N1P1 and N2P2. And in those cases where there was no amplitude density seen in pre-intervention, there was occurrence of amplitude density started appearing post-intervention. This is the logMAR visual acuity chart, which as we can see, it's significant. This is the amplitude density chart between the control eye and the intervention eye. This is again the graph showing this. As you can see, the right eye, you see the heat maps. If you compare from the right side to the left side, the heat map becomes lighter. Lighter means a stronger response. So we see that reappearance of near normal waveform and improved signal strength in multifocal ERG indicates growth factors derived from PRP have led to activation of the diseased bipolar cells, either by interfering in reprogramming or remodeling of the bipolar and photoreceptor cells respectively. Though we understand it's a genetic disease, so gene therapy is the permanent cure, should be the permanent cure, but with 240 genes in play, it seems a distant reality.
Time is up. You need to
I'm finished.
Yes. Was this a multifocal ERG done before and after the
Yes,
injections? And
yes.
how many injections were given?
Ma'am, 3 injections, 15 days apart.
All suprachoroidal.
Suprachoroidal, 2 ml suprachoroidal and 1 ml subtenons.
All the 3 times you gave suprachoroidal
Yeah,
as well
yeah,
as
yeah, ma'am.
subtenons.
Yeah,
in your presentation, you did not mention about the ethical committee
Ma'am,
submission
we have,
and
we have
clearance.
taken all the ethical clearance.
No, that need to be mentioned in while presentation,
Okay.
and that number need to be projected.
Actually, it was very short time, 5 minutes, so I could not.
No, it need to be projected somewhere so that we can read, even if you do not. need to
42 eyes was taken as control as well as for intervention.
project. Thank you very much.
Is it a pilot study of sorts? Is it
Yeah.
the first time PRP is used for suprachoroidal?
Yes, it's a pilot study.
It's a
It has-
pilot study.
Yes, sir. It has also been accepted in international journal, ma'am.
International?
International journal, Cardiac Ophthalmology.
But you have a very short follow-up.
No. There is a
No.
problem. 1 second. Any AIOS, any presentation, you need to give the consent for publication in IJ1.
Ma'am,
That's a part of this thing if you get the award. If the same subject is submitted somewhere for publication, probably that will be a problem
no,
for
sir.
you.
Recently, it has been accepted. When I submitted, it was not accepted at time.
Then again, it's little bit, you are cautioning us, but this I want to tell everyone. Okay?
Okay.
Thank you very much.